here to introduce our panelists, Cynthia Stamer and Powell Hamilton. Cynthia has been repeatedly recognized among the top-rated healthcare lawyers and labor and employment lawyers by LexisNexis, and she is also founder and executive director of Coalition for Responsible Healthcare Policy and its Project COPE, the Coalition on Patient Empowerment. Powell Hamilton, he's the Chief Information Security Officer of Scripps Health, with over 25 years of experience in information technology and management. So I'll let you guys start the panel. Thank you.
Thank you. Thanks for being here, y'all. And we look forward to sharing really an evolutionary discussion about one of the big expanding technologies that perhaps will expand further. I'm required to give you the disclosure that nothing I say can and will be used against me or you. We're not giving legal advice and all that other things. You know, the government does it, but they require me to do it. And I don't think we're going to have any tax advice today. I wanted to just put the background up here because there's a lot of telemedicine and remote care that's been going on. As a person who grew up in rural America, I started health care in rural care. My mother was a public health nurse and did remote care when she came out of nurses training in 1950. And back then they did it with a telephone that dialed, and it didn't store data, and it was a party line. And there were a lot of passing in notes, and they were really just concerned about getting the care for their sick babies, and they didn't really have a lot of distrust, so they didn't about a lot of the things that are the things that, for me as a lawyer, drive things. And so my background started in that way too, because I grew up starting in healthcare with a family that owned a charitable hospital in rural America, with a mother who was a public health nurse, a grandfather who was a dentist, and family members who were basically servicing it. And across the years, I've been given the opportunity, ironically, to work on telemedicine evolution with people working in space, in foreign countries, with employers, with healthcare providers doing remote care all over the world, basically because I'm a little hick from a little middle of nowhere where they couldn't get access to care. And I continue to work on projects not just in the law but in the government, and also in developing some of those. And it's interesting to me how much of those things are the same, but with the different technology and so many of the things that are risk. But there's another component that's really different. And I think our discussion with Bryn that led into this highlights the real problem here. The thing that's changed is the lack of trust. In 1950, Dr. Kildare and my mother were one step away from whoever you think your Savior is. They were so grateful to see him. They trusted him implicitly. They didn't ask him any questions. The quality of care they had access to, they were just grateful they were there. And I can tell you today that I work with clients in far western Kansas, far western Texas, and developing nations where we have issues on reimbursement and remote care, and they can't afford to comply with all these requirements, where patients are dying because there are no doctors for an hour or 2 hours, and they are still just grateful to get care, and the providers still just want to give them care. And if you're also, like one of my clients and best friends, one of the most senior people at a multinational, high-profile technology company that is a major security provider that almost everybody's platform uses, who's a heart transplant recipient, and who just got a heart a few years ago, but lived through 5 years with he and his wife in constant trauma, wondering if he was going to live. And whenever his little heart monitor blipped, Rampart rolled, you're really no different. So remote care has always been something really important, and house calls and telemedicine, but we're in this loop where all the distrust is driving and all the complexity and all the technicity. That's what's different. At the heart of this, though, and I know that Powell lives with it, because I know when I work with my providers, patients just want to be cared for and providers just want to give them care. So when we look at these things, unfortunately, as we started off just now, HIPAA and the privacy rules and the state privacy rules and PCI rules and every other rule, you have trade secrets, all these other things come into play. But it's a really, really big deal today. And it goes on these issues. But there's a whole bunch of other parts, too. And to really start examining that proposition and see if you agree with me, I'm really excited that Pal's here because he's living in the trenches of making those things happen. And if you looked at the slide I put up, he's been doing it for a long time. So what I've asked Pal to do is to just start talking about the different things he's working on and seeing, and help us understand how broadly both the technology and the applications when we say telemedicine and remote care are. So Pal, take it away.
That's the convenience here of being you and I. We can share our mic here. Well, thank you very much. I appreciate everybody being here. Basically, my background is I was, for the most part, a consultant for 10 years with Price Waterhouse and focusing on security, but I did get pulled into the healthcare arena. My crossover was jumping over to Hoag Hospital, and I was the CISO there for 4.5 years. Loved it there, but then I had a great opportunity at the City of Hope, and so I jumped there and had a great experience, 2.5 years there. And just recently, I had an opportunity in San Diego, over 5 hospitals, 28 care centers, to be the CISO there. And so 5 months ago, I jumped over to that space. And I got to tell you, 8 years ago, I started out as a CISO, and once in a while, somebody would come to me with this great idea. And usually it's the physician who presents the idea, and then we have to vet it. And we CISOs don't like to be the no person. As security practitioners, we don't want to say no. We want to say, how can we make it happen? Well, it's at odds because we have a doctor that typically doesn't want to take no or doesn't want to delay the process. So my everyday challenge is trying to be a negotiator, trying to implement the controls in a timely manner when I have somebody on the other side, either a doctor or a researcher, who needs it like yesterday. Or I think we've all been there, and I hate to remind everybody this painful events where something's been implemented and then security's brought in, and then we have to make some quick decisions. So right now, to specifically answer your question, typically what happens is a physician or a researcher will want to do some kind of research or some kind of product that would be a telecommuting type or a telemedicine type product. They'll talk to the technical people and basically say, can we do this? And let's just say the answer is yes. Then they come to security or legal, and we have to vet it out. Now,
let me just, while we go through that, let me make sure we hit a point that you shared with me when we were visiting.
Yeah.
Who do you report to?
Oh, good point. For 7 years, I reported to the CIO, and everybody in the security industry is saying, oh, that's wrong, you're not supposed to do that. I've always been quite comfortable doing that. They're my guys. I can hang out with them. Those days kind of faded away because as you get upper management, I drink less beers with my staff. But I am truly now have a different reporting structure. I report to the VP of Audit and Compliance. I have a dotted line to the CIO, and I have a dotted line to the legal department. So when I put together my weekly staff meetings, I have 3 meetings. And those are 3 separate meetings with those groups of people.
So every time you want to do one of these things, you can't just start looking at technology and saying, oh yeah, we can lift this switch. You have a process you have to go through.
We have a process, and currently my process, I wrote down because it does get a little lengthy. The first thing we have to do is, typically it's a device is involved. A device or a cloud, or a combination of both. So we have to do a technology review of the device and or the cloud. I like to punt it to the engineers, have them do a review, come back to me with the data, and then I can review that. If it's a third-party company that's managing the device, I give them a questionnaire that's about 25 to 30 questions, really broad, your typical questions. What is the access control? What is the logging? What is, about 30 questions, and then they come back to me and I have to assess it. Actually, you guys would be surprised how upfront and honest some of these companies are, saying how they're short with some of these areas. And so what I do is what I call a light risk assessment, and I put a rating, and I don't say pass or fail, I just put a rating, and then obviously I go back to the business groups and I ask, will we accept it at this level of rating? One of my past environments, we did reach some that did not meet what we felt was the standard and our minimum requirements. And that's a tough one, because then they come back to me, what are your minimum requirements? And now I have to go through this paperwork. So now you can see why doctors and researchers are starting to dislike me. This takes a long time to do a back and forth of getting information and finding out what their controls are. I also have to take it a further step. Now I ask for, what are your insurance? So I need to make sure that the third-party vendor has cyber insurance of some type. And then I'm working with the legal department, and they say, well, we have a certain limits, and we need to make sure that their cyber insurance reaches these limits. I also have to request external reports. Do you have any SAS, or do you have any escapes me right now, the latest accounting type reports, but I'm looking for any type of review, any PCI reports, the ROC, and anything that would help give me an understanding of their environment. We also do a scans. Not only will we do an external scan if it's a cloud situation, we'll do a we use Web Inspect, and we'll do a Web Inspect. So all this takes time. So really, again, back to the doctors and researchers, they're annoyed with the process because it takes so long. And if somebody's on PTO or somebody, it all slows down the process, and that's where a lot of frustration is. Mm-hmm. But if you think about what's going on now, I would say that I probably get a cloud request probably about once a week. So if people in the room knew my background, I did start techie at once upon a time. I thought I was a pretty good attack and penetration guy. Those days are gone. I'm lucky I could boot up my computer. I'm so much into the reading contracts, making sure it has the security language in it. I'm into these controls, assessments, what are the rankings, and I work close to the engineers that help interpret all this information. So my life back when I wrote code, those days are long gone, and actually that was all holding me back in my career. But nevertheless, the tip of the CISO's roles and responsibilities have definitely changed, and I'm finding them really challenging right now because of the cloud and remote technology. So,
Powell, you, as one of the leading sort of research and treatment facilities, have been involved. Your organizations are at the cutting edge of some of our big emergency issues like contagious disease and containment, which we're going to have a great panel after this one on, but also a lot of other consulting relationships with other providers. So in your world, yes, you have day-to-day treatment with people that are in proximate location to you, but you have a whole host of people that you're one of those centers of excellence that people come to you as patients and then go home to be treated with some remote supervision. You have people that come to you who don't actually ever get to you, but you might do consults. You have people out in the field like that. And it strikes me that that's another kind of remote care. And for example, in some of those, that whether it's the Ebola kind of crisis you got a crisis on, or a situation when an oncology patient tanks or has some urgent things, that those recurrent relations in essence give rise to exigent situations that are kind of in your flow of life. And, a telephone today is a digital item. It's a computer. And I just thought that probably you would be uniquely have some experience and perspective if you could talk about your awareness of that and how, with these continuing situations where you have a relationship where the situation it's not one of these neatly little things, but CDC's coming and we need you to take a patient now or something like that. How does that process change? Does it go into an emergency intake process? Do you have a special procedure, or have you already done sort of an intake process and planning just overall for that? How does that work?
Well, as far as the emergency situations, we really haven't gotten there. Mm-hmm. We do have some pilot programs on telemedicines that we're working on, and quite frankly, it's not the consultations. It's coming up with the cost. It's the business side that's causing the challenges. So we can have a patient talk to a doctor. That's the easy part. The technology's there. It's how does this doctor get paid? How do we get the time to do it? One of the pilot programs we have with our staff, we haven't gone to our patients yet, and this is a public app, is Doctors on Demand. We have all of our employees, they have the option to sign up for that, and using our insurer, they can fill out that information and they can go that direction. So that's an option. Really, it's the payment plan that's difficult. How do we get their deductible and all that going through? There's a lot of competing ones. Before we chose this particular one, we did use MD Live. I know there's Ask a Doctor, Live Health, WebMD. They're all trying to get a application on your smartphone so you could use that device to help diagnostics. But it was a challenge. Even in the last presentation, we talked about how carefree patients are. For example, you load that application on your smart device, you just want to get that application running, and what does it do? It prompts you, will you accept all these access? And we don't barely read them. We just say accept. And I know you as a security practitioners, you've heard this, you know it, but we still are doing the same thing. So, and we're accepting. Accepting the rights, we're also accepting that we will share this information. So in the last presentation, they talked about big data. This data now can be used as other information. So, for example, if I have a cold, I guess that's no big deal. I'm looking for cold remedies and stuff like that. But if I'm actually going on there and I'm trying to diagnose myself, and before I talk to a doctor, that information can be used for other things. Mm-hmm. And by accepting the application and installing it on my system, I'm actually accepting the risk and the data being used elsewhere.
One of the issues that comes up with that, and I'm curious about whether you've encountered it, having worked with a number of the disease management organizations, they do screenings and things, and there's other organizations that go out and try to identify potential candidates for research studies and things like the lab. And they're partners in that process. But I think one of the questions that often comes up, you're getting data, they're answering for almost to make you a candidate for a study or an assessment, and then you get the assessment. And it's inherently necessary to find those patients. But one of the questions that comes up with that is, when do they become patients? When does it become PHI? And, it's identifiable in any given ways. I think all of those aspects, the answer is, I think we don't know. And I know that's one of the things that's inherent in this topic is, who would have thought, if you read the different enforcement actions, first of all, what's the patient thing on consent and understanding? And those aren't regular healthcare things. Those are just, I did a book on e-torts and other technology for BNA several years ago. And people go, why would you do that? But everybody's focused on HIPAA and authorizations. It's like, well, click on this. Every state has a different rule of what's consent. California's very restrictive. And, so there's all those elements as well. And I assume legal coordinates all those with you when you talk about the contracting.
So legal and I have become best friends. I have to look at just about every contract that comes through that has a security component. In my last role as well, I probably spent 25% of my time reviewing contracts. I don't have a law degree, but working with the lawyers in my organization, I'm helping them say, this language should be there, we should probably get rid of this language. We're also having some of our partners push legal requirements onto us as well. A very large organization that had a breach recently is now pushing strong requirements onto other organizations such as ourselves, and we have to change our policy to meet their policy, and that's been a challenge, especially recently, where I have to change a whole bunch of controls. One control that frustrates me a little bit is changing the password every 90 days.
As a patient, that frustrates me too.
Yeah, and I know this is a little off the telemedicine, but that's just an example of the working relationship where, I guess it's proactive with PCI because that's their requirement. Now that's their requirement. Our current requirement is 120 days, and now I have to change that immediately because of a contractual obligation. So, I love you lawyers, but you make my life a little more...
I don't want to take credit. I'd like to pass it up to the Office of Civil Rights, And
then another thing, research is interesting, especially with our where we're located. We actually do a lot of research down south. So that's an area where some of the HIPAA rules don't have a reach. But that information is then transferred, say, to a cloud in the United States, so all of a sudden it does apply.
Right.
So working with a group that says, we don't need no stinking badges, well, actually you do, because now you're talking to systems within the United States, and I have to make sure that, again, I go through my little checklist of device review, cloud review, insurance, reports, and then I have to do all the scanning. So, I do have a process in place, which, like I said, I call it the light risk assessment, but unfortunately it takes time, and again, I upset physicians, researcher, or any other requester of a outside resource. Well,
that's the sort of bad and ugly side of your job. When we visited, one of the cool sides of your job is all the cool stuff you're seeing and thinking about doing. And that, we've talked a little bit about some of the things, but really the breadth. I was talking about moving from the telephone and the lady going around door to door, following up once a month, with making house calls. We're making virtual house calls in a lot of whole different ways with a lot of different technology. And as we move on to sort of taking those comments and moving back, open up our eyes and talk about sharing some of the experience of the remote and telemedicine things. Telemedicine is a term of art. It depends on what you're talking to. From a lawyer's standpoint, what is telemedicine depends on which telemedicine statute, rule, and regulation you're caring about. In the industry, I grew up with one of the ladies for one of the big phone vendors that runs the telemedicine group, and they have a whole different version for their phone company of what is telemedicine and here in technology. So when we talk about telemedicine here, because the laws are changing and it depends on where you are, it's more of a conceptual issue. You have to figure out what it is and to trigger the regulations. But we know the privacy and all these other issues come in there as well. But I think when we really start thinking about it, starting with the telephone, anytime you pick up the telephone, you've got technology and remote care with the patient, if you have a patient relationship or prospective one. And I think as we look at some of these things, we need to remember that there are those basic things that have been there before time, because if we look at some of the things, like calling in to verify or some of the recent rulings, people are really focused on these really complex things, and they forget it. So when I go out and speak about data breach, whether it's in healthcare or something else, and I say to companies like the person that owns the diner, Chamber of Commerce, are you a technology company? Do you have secure data? Oh, no, I just run a diner, which is what the person down in the hospital cafeteria says too, right? I go, do you have a phone? iPhone? Do you transmit back and forth? You know, we know that, but they don't. So we can't overlook those basic things, but building off of that, what's the cool stuff that's happening out there? What are you working on?
Well, some of the cool stuff is, as you know, like every hospital environment, we have to reduce costs. So we're looking for ways where we can reduce costs, and sometimes that's labor. One of the areas that we're trying to do that is like remote monitoring. We have some situations where it almost has to be a one-on-one monitoring situation. Maybe it's a mental health issue, or maybe it's a patient who has a heart issue or something like that. So we have a lot of one-on-one monitoring. So now we're looking at setting up cameras so we can obviously have multi-monitoring. Expanding that, the monitoring in the home is always a question, and consultations in the home. That's a challenge because, again, I'm looking at devices. I'm typically was growing up looking at an infrastructure and securing an infrastructure. Now I find out that all the biomedical devices have now fallen under me, and I have the responsibility for that. One issue at the last 3 environments that I've been at is how many servers, how many workstations do you have? Let's say you have 10,000. Oh, that's easy. I get 10,000 licenses for my scanner, and I scan these on a regular basis, and then I maintain it. All of a sudden, I inherited biomedical devices, and now you add 20,000. And then I have the challenge of, are the devices in use? Because then I can't scan them while they're in use. So I have to work with the departments to find out what is the downtime for those, and logistically it's been a real challenge. Now you add home type devices and remote type of devices, and I will check those out, but who's to say that the configuration changes or modifications didn't happen while it's away? And as security practitioners, we have to keep monitoring this stuff to make sure nothing's changed or nothing rogue has popped up. And in those environments, it is a challenge. So we have a check-in, check-out scenario, and when it's checked out, I'm comfortable. When it's checked back in, I have to make sure it hasn't changed. If it has changed, then we have to follow up to say, why did that change, and did it affect the patient health when it was out of my eyes and ears?
Well, you know, and one of the things with all the little smart car problems and things like that everybody is increasingly concerned out of is not just securing the data, but protecting these things against hacking and other kinds of attacks as a way to hurt patients. And I'm curious, because they're remote and they're pushed, have you added that into your plan? Are you looking at that, and what are you thinking about?
So we're looking at each type of device and saying, how can we best manage it? The problem there is, every time we look at a new device, it seems like we have a new process. And so I'm coming up with 10 processes of remotely managing, and that's becoming overwhelming. I am fortunate that we do have some security practitioners who focus on biomedical devices, but these people are being pulled in many directions. We may have, let's just say, 10,000 internet or IP-enabled devices, but we may have, 50,000 that aren't IP-enabled, but may retain EPHI, and we have to work with those. Yeah, those are a challenge.
Another trend that goes with that is not just pushing the patient care out, but also the team is being more dispersed. We have more people on call. We have more people working from remote places, which we also, maybe from home, flex time, they do on demand and all of those sorts of things. And what kind of complexities, does that make as well? Are they using an Apple phone? Is their home computer encrypted? How are you process-wise incorporating those issues, or how are they impacting you?
Well, I remember when two-factor first came out and we all had our little FODs that we carried around. Since then, it's evolved to your smartphone and send you a pen and all that. And quite frankly, right now, that is a major focus. And that's a major cost issue. Mm-hmm. But that's nevertheless the direction. We're not only going from a right practical route, but because of compliance, we're being forced to go that direction. Typically in the past, I've shared my budget, my project plans with the IT group. Like I said, for seven years, I reported the CIO, and they had that under their budget umbrella. Now I'm being separated, and I'm coming up with my own budget, which on the surface sounds real nice, but all of a sudden I got the shift of the budget, but I didn't get the shift of the labor. And so that's a challenge of getting the IT folks to help implement the security projects that I want to implement. Again, for those 7 years when I was reported under the CIO, they had to, that was part of their work effort. Now I'm an outside, I'd like to say I'm a customer, but I'm not treated like a customer just yet. Mm-hmm. And but I do have a great relationship with the CIO, and when I'm not getting support to implement a security project, I'm afraid I do run to daddy and I complain. So.
Well, you have good access, at least.
No.
Yeah. Well, let's thumb through a couple of things real quick in terms of positing, because we want to leave some time for some more dynamic building on that, and then we're going to come back and talk about some of the issues that are on the proposal. So what I have in mind here is just this basic reminder that to do this stuff, as you can see with Powell, and he's just touched the tip of the iceberg, you've got to deal with all the normal things that you have to deal in any healthcare situation with a lot of complications. And to do that, you've got to understand a whole bunch of stuff. Gosh, amazingly, legal ethics, medical ethics. Is it, one of the big issues I've worked on for a policy issue starting back from the days of Teledoc, before it was, is whether you can prescribe by remote and the Ryan-Haight legislation. And it keeps coming full circle. Back then, you couldn't do e-prescribing. Now you have to do e-prescribing. The world is funny that way. There's so many things there. There's those technical things that I throw my hands up and say, would you please plug this in for me? And we had a discussion with some of our folks last night about whether something did something in technology, some of your speakers that are here today, and I said, I look to people like you to tell me that. I tell you what it has to do. I get a credentialed expert, which means you got to get a credentialed expert, and Powell's talked a little bit about that. You have to meet all the privacy, data security, the big R reimbursement, quality, contract, and all these other things. And inherent in that is workforce, partners, and something really important that the doctors care about and you care about, and everybody shares it, but when we're all trying to get our job done right, patience, because that's why everybody's there. Now, as we go into this phase and just kind of overall, I just want to remind you that we're not trying to tell you what the rules are today or exactly what works or what doesn't. It would be totally unfair for me to put you or Pal or anybody else in that position. But we're basically sharing what we see and inviting you to join that. And the reason for that is that it's not a fixed situation. It's a really moving target. Things are in flux. The technology, the rules, what works, what doesn't, where it happens, and the like. And so it's still evolving. And even if you had a legal opinion, when people ask me for a legal opinion, what I tell them is I'll give it as of a certain date based on exactly what you showed me, but I will not guarantee you by the time you get the paperwork that it's still relevant to your situation. And I think the other thing about that is that we all have to understand, and that's why Pal being here and y'all being here is so critically important, is if anybody hasn't gotten it, they don't care if it's job to care for the patient. If you cannot get the data secure, they will pop you. And so you can see these things. I just came back from I go every year and lead a meeting with the Office of Civil Rights, and we talk about all those things they do to you and tell them how impractical they are. And what we know, and you know, but it's really pretty revolutionary. The most current data they have posted, I pulled this morning, is as of 2014, and you're seeing this rollout right now of a whole bunch of other enforcement. And look at the rise in the complaints. And what you also see about this, if you can't see it, is that safeguards and people interface are huge. And in the historical things, it's the number one problem they have that they're hitting, and they've just said, if you don't encrypt it, if you don't control it, we're going to have a thing that's a problem. But anybody that's doing something off-site, it gets more complex, because when Pal's working with his folks, he's got technology changes and these things changing. All those business partners, all those patient partners, all those employees, they have other technology, and they're not necessarily in sync. So what he's told you is he's got to change his stuff because somebody else is rolling. It's like a constant tsunami. And that's why when you look at this pie chart, which is actually last year's data, because they haven't made their pie charts yet, but what you see is laptops, network servers, portable devices, and when you look at paper record problems, it's almost always remote or off-site care. Then just look at the last few months. Now, I live my life every day. I check the website, because every day there's something new, because they're making it up as you go. They're telling what you did wrong retrospectively. And the first thing I want to tell you is all these recent settlements are 2012 or before. So they basically are taking years to decide what you did wrong and come out and tell you. But for example, they have made it clear on the University of Washington Medicine, $75,000, you must implement a system-wide systemic process and procedure. And when you do that, and you're dealing with remote care and remote partners, the system, as you can hear, becomes huge. Proposition 2, get your business associate agreements right. Now, as a lawyer, I have ethical obligations, and then I'm a business associate, right? Sometimes, because I do ops work, I'm operations counsel, I live in the trenches. That means I've told them about the HIPAA, so when they ask me and then they try to go for an investigation or trial counsel or some consultant off-site, and they want me to send it, I'm a business associate, but I also have an ethical obligation to watch out for them. So I've had this issue come up several times where the person that's been engaged, that's that $175 an hour defense lawyer that you have on your malpractice or your liability, and they go, well, I don't need that. I'm not going to redisclose it. Oh, by the way, they do attach it all the time. And we get in this situation where I've asked, can I give it to them? I have interesting information for you. Discuss this question with them. And I asked why in this recent enforcement action they popped the covered entity but not the business associate, because I've always been afraid I'm going to get popped as a business associate. And they said they didn't pop the business associate because it's downstream. If a business associate doesn't get it downstream, they're in trouble.
Can I share?
Yeah, go ahead.
A real proactive thing an exercise we did at one of my past organizations was we did a BAA, a vendor review. We had some issue with a vendor, so we told the board that to react and remediate, we're going to go through this exercise. We went through that exercise, and we got a third party to help us come up with a survey. We identified all our BAAs, which They always need to be cleaned up. You have a list, but when you really drill through that list, you find out it's something smaller. We sent out the surveys, and again, that honesty was appreciated because a lot of the vendors came back saying they're not meeting our requirements. We did not expect that. So now where do we go from there? Do we tell them we come up with a remediation plan that they have to meet it by a certain deadline? Do we drop them as a vendor? And the answer was all of the above, but we were shocked at the results, and it was a very proactive exercise to reevaluate all our BAs. Moving forward, now where I'm at, that is one of my audit plans moving forward. I'm going to do that every year. Because when you have most of the breaches caused by your relationship partner, and you get blamed because you're the big entity, that's a risk we just can't take. So if I was going to tell somebody as far as a relationship, I would try at least on a periodic basis, I'm doing it annually, to reach out to your partnerships and just ask them in a survey, are they meeting your requirements? Again, I was shocked because it was like about 23%
and verify that you actually have a current signed copy and contact information for those things. You know, because the second thing, guys, if it's not encrypted, but remember, there's all these moving parts. And so, and every time you load something, I'm always amazed at how much that does. And there's so many of it. This is just the latest one, 3.9 million. But all the big settlements are lost data, breaches that come from lack of encryption and security. Think about the interfaces on these clouds and the websites where you're using portals. You know, it just gets screwed up. I mean, a lot of these things are not people. People, first of all, don't always understand encryption. So the fact that you hire somebody and they say we're fully HIPAA compliant. But also, it's a lot of these things have happened because they did it at the first place. But then, as we've seen with the copiers and the websites and the other things, you need to recheck it. You know, the medical device thing. $850,000 for not securing the medical device is just there. But I want to point out to you something that beyond just these resolution agreements, when I say go to the website, it's like pops up every day for me. There's also this other area of corrective action they take that isn't these $1 million settles, but they basically have small things that they correct. This is just one, and there's a whole bunch of them. And I wanted to point it out here because all of this stuff involves some sort of telephone, basic communication, and verification on remote care on those things is a huge issue. And so basically, they didn't have a process for doing that. So when you look at all these things, there's a whole bunch of other interactive things that you have to work with. So you got to also make these things work if you're prescribing and coordinating. I know there's that really simple thing you work with called the EMR, and making it work not just as a secure data, but for billing and coding and record keeping, and I know that's just been a piece of cake for you all. We have EDI, ICD-10, and other coding and billing issues, and would it be fair to say that your theme is no money, no mission?
We're always broke.
Yeah. Every single person in your organization has medical ethics and legal standards of quality, and the standards of quality are exploding. So you have that sort of board of medicine and sort of Socratic oath, and then you keep the Hippocratic oath, and then you got Joint Commission, and you got this credentialing, you got that credentialing, Leapfrog, whatever you're participating in. Then Medicare comes in, and for their reimbursement, they have another standard. And if you're in an ACO or you're contracting with the health plan, they have another standard. And oh, by the way, I know the health plans are also struggling both to secure their data but get the data. You got to get all that security data there, but if you block the data so you can't get the records, you don't get paid. You got the contracting issue that you've alluded to. It goes on and on. I guess what I would say to you here is that we need to continue to dialogue, and as we go to the next section where you're talking about some of the contagious disease and some of those other things at lunchtime, you'll see an even fuller place of those things coming and some of the complexity that comes into it. I think we could all agree that we need to have PAL, and several of you all come back on a regular basis, and we need to be continuing not only to collaborate and share experience, because there's just so much that if we don't share our thoughts, we miss it. But we also need to be taking that collaboration back with Bryn's leadership in First Before and participating, because one of the reasons we get such stupid guidance, and it is stupid, is because the people that make the rule are too far remote from the people that are responsible for administering it, and that's part of the problem. So I know we're going to be here. I know a lot of your speakers are going to be here, and I'm always excited that we get to come back. I hope that you will have enjoyed this, you'll be energized by it, and it'll be a part of the dialogue. And I also would like to ask you to join me in thanking Pal for coming up here and sharing what's been a really pragmatic and insightful perspective based on somebody that's been in the trenches for a long time and has been dealing with it in a lot of different environments. So thank you for coming, and help me thank him.